All right, good. Hello, everybody. Welcome back. This will be your video lecture for Chapter 41, Environmental Emergencies. I'm going to go ahead and apologize in advance. This is going to be a lot of reading from the slides. There's just not a lot of theory behind this, but there's a lot of facts, and so we will cover it. I'm sorry again if I'm reading from the slide. I normally don't like doing it that way, but sometimes when you get into some of these chapters, it's the only way to do it. All right, let's get started here. Let's look at the introduction. We'll talk about environmental emergencies that occur when normal body processes are affected by external conditions. We'll talk about things like temperature, submersion in water, lightning, and changes in atmospheric pressure. When cold, body conserves heat. When hot, body eliminates heat. When body mechanisms are no longer effective, an emergency situation occurs. Be aware of risk, take measures to protect yourselves, then protect your patient. So heat and cold related emergencies, the body maintains a normal core temperature through something called thermoregulation. In an extreme environment, in extreme environmental temperatures, body thermoregulatory mechanisms are overwhelmed. So a lot of those mechanisms start in the brain, like temperature is controlled with the hypothalamus. And when you start getting outside of those, into those extreme conditions, whether it's hot or cold, the brain starts, dysfunctioning, just like any organ under stress. So body temperatures increase or decreases, leading to illness. A couple of those hot conditions, we would expect hypovolemia and loss of electrolytes. And in the cold conditions, we would consider frostbite and other related conditions from cold weather. Let's look at the anatomy and physiology. Let's look at thermoregulation. That's the process by which the body regulates the core body temperature. The core temperature is defined as the temperature of the blood and internal organs. The body detects core temperature through thermoreceptors, and those are sensory nerve endings that monitor temperature within the body. Again, I mentioned the hypothalamus earlier. That activates temperature regulatory mechanisms. Some of those would be like thermal gradient, and that's the difference between the body and the environmental temperatures. Thermogenesis, so that's actually the process of generating heat. Thermolysis is 5 processes of transferring heat from the body to the environment. Let's talk about a few of those. Number 1 would be conduction, and that's the actual heat transfer from the body to cooler objects by direct contact. So this would be like leaning up against a steel door, something like that. Convection, this is heat transfer to air molecules passed across the skin due to a moving air current. Like convection would be like standing in front of a fan. Radiation, this is heat transfer from the body without physical contact. Evaporation, sweat vaporizing and dissipating from the skin carries heat. And then respiration, heat loss through exhalation of warm air and inhalation of cold air. And so here is an image of the mechanism of heat loss that explains those 5 conditions. Risk factors for heat and cold related emergencies. So patient age, right? Whether it be super young or super old. The patient's health. What is their overall health? Do they have chronic medical conditions that being in a hot or cold environment could make it worse? Certain medications the patient may be taking the length of the exposure, the intensity of the exposure, and socioeconomic factors. So the environment does not have to be extreme for problems to occur. Patients with impaired thermoregulation are at an increased risk. During that scene size up, you want to look for clues to the nature of the emergency for the potential hazards. Temperatures of 90 degrees Fahrenheit or greater, relative humidity of greater than 75% makes an ideal situation for heat emergencies. A lot of times, these it says identified number of patients, because let's say you're at a concert and it's summertime, lots of people can be affected by the temperature and by the humidity. You may need additional resources like additional ambulances, or you may need people to provide triage. You always want to form a general impression of your patient. This is an image of the temperature versus relative humidity, and it kind of gives you the, on the bottom here, like 80 degrees Fahrenheit to 90 fatigue, and then 90 to 105 sunstroke, and then you can read that and take a look at that. So on the scene size up, number one, scene safety, protect yourself, right? So we want you to, if you're working a concert or maybe you're working an event outside that's cold, maintain an adequate fluid intake. You want to allow time for gradual acclimatization to heat prior to a physical exertion. Limit your time of exposure, and in cold weather, dress appropriately. The primary assessment of your patient, a decreased LOC jeopardizes the ability to maintain an airway. It's in every chapter, right? Anytime you have someone with a decreased level of consciousness, that should alert you to a possible airway problem. Maybe not then, maybe later, but it should get your attention. Extremes in temperatures can affect circulation, affecting heat function and fluid loss. You want to make sure, as always, that we ensure good ABCs, address any immediate life threat. You want to remove that patient from that hot or cold environment as quickly as possible. Take measures to stabilize that body temperature and determine the criticality and status of your patient. During that secondary assessment, this is when vital signs can be obtained, samples can be performed. You can use of monitoring devices can provide valuable information. This is when we would use a pulse ox, a CO2 monitor. Obtain information related to the events leading up to the emergency: temperature, humidity, wind, length of exposure to the environment. And then, of course, reassess every 5 to 15 as needed. Specific heat-related emergencies, we'll talk about heat cramps, heat exhaustion, and heat stroke. Heat cramps, they're the least severe of all heat-related emergencies. Muscle groups can cramp in response to overexertion and dehydration in a hot environment. The primary problem here is the loss of electrolytes, sodium and chloride. Signs and symptoms: cramping of the larger muscle groups, weakness, possible complaints of lightheadedness or dizziness. Management: let's remove the patient from the hot environment. Let's administer oral electrolyte replacement fluid and maybe gentle massage. Heat exhaustion. This is a moderate heat-related illness that can lead to inadequate perfusion, mild states of shock. This could increase vasodilation in the peripheral circulation. Prolonged and profuse sweating can lead to a loss of circulating blood volume, like your plasma, and thus inadequate circulation. Signs and symptoms here: be a body temperature greater than 100 degrees Fahrenheit, cool and diaphoretic skin, tachypnea, weak pulses, muscle cramping, weakness, headaches, dizziness, anxiety, and maybe an altered mental status. Remove the patient from that hot environment, removing heavy clothing. Do not allow the patient to become chilled. Administer fluids orally if the patient is alert and not nauseated. That's the problem. Once they get nauseated or they're not alert where they can maintain their airway, then we lose that ability to provide PO fluid replacement. Heat stroke is a life-threatening condition. This is when the body's thermoregulatory mechanisms cease to work. Normally, we see this around a core temperature of 104 degrees Fahrenheit. The mortality rate can be high, 20 to 80%. The core body temperature rises uncontrollably, and this results in destruction of brain cells. Classic heat stroke, an elderly or ill person is unable to escape the hot environment. Exertional heat stroke, those working in a hot environment, main concerns for us, for firefighters. Signs and symptoms, right? And the big one here is that we lose all the cessation of sweating. The skin, instead of being cool, diaphoretic, becomes hot and flushed. The high core body temperature, we have a lot of brain cells that are dying. And so now the brain's going to start producing a real nervous system problem. Deep, rapid respirations, which can become slow to even shallow. Tachycardia, which can proceed to bradycardia. Nausea, vomiting, hypotension, and possible seizures. So rapid identification and rapid effective treatment can decrease morbidity and mortality rates. First, let's remove the patient from the hot environment. Rapidly cooling by removing clothing. This patient needs to receive 2 large bore IVs of an isotonic crystalloid solution, right? So normal saline. And be prepared to manage seizures. So let's talk about cold-related emergencies. Generalized hypothermia. That can be defined with a core body temperature drops below 95 degrees Fahrenheit. Severe hypothermia is a life-threatening condition, and the mortality rate here can be as high as 80%. The body's thermoregulation mechanisms fail. The core body temperature quickly falls. We have a decrease in cardiac output that can eventually lead to cardiac arrest, and death can occur quickly. When we look at mild hypothermia, this can be defined by core body temperature that's between 90 and 95 degrees Fahrenheit. In severe hypothermia, this can be defined with a core body temperature less than 90 degrees Fahrenheit. Treatment is going to depend on the degree of hypothermia. Number one, though, is we need to remove the patient from that cold environment. The 5 stages of hypothermia. Stage 1 is shivering. Stage 2 is apathy and decreased muscle function. Stage 3 would be decreased level of responsiveness, followed by stage 4, decreased vital signs, and then stage 5 would be death. In generalized hypothermia, let's do our best to stabilize the temperature. Handle the patient gently. These patients are suspect to cardiac dysrhythmias, and one of those main dysrhythmias being ventricular fib or VFib. And so that's why we want to handle them gently. We want to remove wet clothing, cover them with a blanket and moisture barrier. We want to monitor that core temperature along with the cardiac rhythm. In mild hypothermia, we can apply heat packs. We can start IVs with warm IV fluids. We can give warm, sweetened fluids orally to the patient who's alert and they're not nauseated and capable of maintaining their own airway. Do not give beverages that contain alcohol or caffeine. Severe hypothermia, do not attempt any type of active rewarming with hot packs or IV fluids. If pulseless, start CPR and use your AED. Uses of advanced airways to provide adequate airway and ventilation. And consider transport to a facility with cardiac bypass capabilities. Here we have figure 41-4. It's showing a thermometer, and it's titled Signs and Symptoms of Hypothermia. It's related to core body temperature. It's pretty interesting. You can look at the temperatures here, and I'll let you look at that. Local cold injury. So we can have frostbite, and frostbite can be defined as intracellular fluid freezes, frozen fluid crystallizes and expands, and this can cause tissue damage. Superficial frostbite or frost nip. These are the superficial layers of tissues that are affected. Tissue feels firm superficially, but soft beneath. So here we have an image here of some frostbite to the feet. You can tell the extremities have turned black, and this tissue is more than likely dead. Frostbitten areas not thawed in the pre-hospital management. So we don't thaw them. Do not massage or rub it. If you must allow the area to thaw, first administer analgesics. So this is going to be extremely painful. We can do Toradol for that, but they're going to need a lot more than Toradol. Transport patients to the hospital for the rewarming to begin. You want to cover that frozen or thawed part with a dry, sterile dressing. Place dressings between fingers and toes and bandage loosely. Avoid breaking any blizzards and keep the part elevated. To protect yourself from frostbite, tight shoes or boots reduce circulation to the feet, increasing the risk of frostbite. Windy conditions increase the rate of heat loss. Be aware of wind chill factors. Cover exposed parts, and caffeine and nicotine increase the risk of frostbite. Trench foot or immersion foot can be defined as a localized cold injury that occurs when the feet are immersed in cold water for long periods of time. Let's look at drownings. Adolescents and adults drown more often in ponds, lakes, rivers, and oceans. Spinal motion restriction may be considered if obvious signs of trauma. We want to remove the patient from the water before attempting to begin any type of chest compressions. And the victim may live or die after this process. Whatever the outcome, he or she has been involved in a drowning incident. Possible underlying medical conditions: hypoglycemia, seizures, syncope, myocardial infarctions, stroke, anxiety disorders, exhaustion, hypothermia, and alcohol or drug use. So the pathophysiology of a drowning: following submersion in liquid medium, patients first voluntarily holds their breath. The reflex to swallow of water occurs. If the patient aspirates small amount of water, laryngospasms occur, which constricts the airway. Carbon dioxide levels in the blood increase, and of course the oxygen level decreases. Those laryngospasms eventually will relax, and active respiration, but gas exchange cannot occur. Hypoxia, hypercapnia, acidosis leads to cardiac arrest and organ injury. The longer the patient submerged, the poorer the prognosis. Other factors that influence the outcome will be the cleanliness of the water. Does it contain pathogens or chemicals? The water temperature. Patients can be apneic for a longer time, while hypothermic than while non-hypothermic, right? Patient's health, the overall patient's health and pre-existing medical conditions. They can't tolerate hypoxia as long. Assessment management may or may not be out of the water when you arrive at the scene. If you're not trained in water rescue, don't attempt the rescue. If water rescue resources have not already been dispatched, request them immediately. The scene size up. You want to assess for hazards, ensure your safety, determine what circumstances led the patient to be submerged, decide if spinal immobilization is needed, and of course, develop a good general impression. If no pulse, CPR and an AED should be applied. The patient doesn't have to be completely dry for the AED to be applied. Dry them as much as possible. If pulse is present, assess the ABCs and correct the life-threatening problems. Suction the fluid and use manual airway maneuvers to open the airway. Assist ventilations if necessary. Check for the control of external bleeding and assess the patient's O2 saturation. Perform a rapid trauma exam. So you need to do your head-to-toe assessment. Obtain vital signs in the secondary survey. Perform a focus exam. And perform a head-to-toe exam at decreased level of consciousness, right? So if they're still conscious, you can do that focused exam. However, if they're altered, then we need to do a head-to-toe survey. The management will be aimed at improving oxygenation and perfusion. Be alert to the possibility of hypothermia. And en route, reassess every 5 minutes for critical and every 15 for non-critical. So let's talk about dive emergencies. They occur due to effects of pressure exerted on the body in deep water, particularly when the diver breathes compressed air from a self-contained underwater breathing apparatus, or scuba. The effects of pressure underwater, depth, and pressure directly relate. The deeper you go, the more pressure or weight will be exerted on you and on the gases you breathe. Dysbaryism is a medical condition resulting from changes in pressure. Water exerts more pressure than air, so for every 33 feet of water exerts 1 atmospheric unit of pressure. Remember Boyle's law, the volume of gas is inversely proportional to its pressure. And we can also reference Dalton's law. The total pressure of a gaseous mixture is equal to the sum of particle pressures of each of the individual gases in that mixture. We have Henry's law. Solubility of a gas in a liquid at a particular temperature is proportional to the pressure of that gas above liquid. And Charles' law. All gases will expand equally when heated. So the assessment and management of a dive emergency, the time of onset of signs and symptoms, what type of breathing equipment is being used, what was the depth of the dive, how many times or the number of dives, and the duration of each dive. Whether aircraft traveled, followed dive, or whether a cabin was pressurized or unpressurized. What was the rate of ascent? The experience of the diver, the previous decompression illness, medication, and is there any use of alcohol or drugs? Specific diving emergencies, we look at barotrauma, right? When air pressure in hollow spaces of the body rises too high or drops too low. During the descent of diving, barotrauma, called the squeeze. When pressure within the sinuses cannot be equalized, an injury can occur. So we might see these patients having mild to severe pain in the ears or the sinus region, discharges of clear fluid or blood from the nose and ears. dizziness, tinnitus, or even hearing loss. Decompression sickness, we have the bends, and the bends can be described as a nitrogen gas bubbles that are produced and accumulate in the blood and tissue as a result of a rapid ascent during a dive. A controlled ascent or staged ascent, the diver will ascend certain amounts and then pause to allow equilibrium of pressure to occur. This acts as an air embolism. Hang on one second. This acts as an air embolism in the bloodstream, stretched blood vessels and nerves of the body, and severe pain, usually in the joints of the abdomen. So let's look at type 1 decompression sickness. This is a mild form that affects the skin. In type 2, this can be caused by nitrogen bubbles in the nervous, respiratory, and circulatory system. So here we have a hyperbaric chamber that the patient can be placed in to try to provide equilibrium. Decompression sickness, recompression, places the patient in a hyperbaric chamber. Patient can be subject to pressurized oxygen therapy to force nitrogen to be redissolved. And gradually decompressing to allow nitrogen to escape again without formations of bubbles. We want to manage the airway, breathing circulation of these patients, provide high flow oxygen, transport in a supine position, IV access and fluid therapy as indicated, and if air transport is used, the patient must not be exposed to decreased barometric pressure. Arterial gas embolism, if ascent occurs too rapidly or if divers holds his breath, nitrogen bubbles will form in the arterial bloodstream, and this condition can be rapidly fatal. Nitrogen narcosis, commonly called rupture of the deep. State of stupor resulting from nitrogen's effects on the cerebral function. Divers may act intoxicated and take risks that he ordinarily would not take. You have the martini effect. This feels like you have had one martini for every 33 feet of depth descended. I've always said that I may not really enjoy diving, but if there's a martini effect, maybe I'll look into it. High altitude sickness. This is a decrease in atmospheric pressure. When ascending to high altitudes, you must do so gradually to allow the body to acclimate. Failure to allow acclimation can lead to hypoxic environments of higher altitude may result in illness. Quickly bring the patient to a lower altitude. Acute mountain sickness. A person ascends to an altitude of 2,000 meters, 6,600 feet, too rapidly. Mild signs and symptoms, lightheadedness, mildness, short of breath, weakness, headaches, nausea, vomiting. Severe signs and symptoms, profound weakness, severe vomiting, significant shortness of breath, altered mental status. Make sure you ensure the adequacy of the ABCs and bring the patient to a lower altitude. High altitude pulmonary edema, or HAPE, non-cardiogenic pulmonary edema, occurs at altitudes of 2,500 meters or greater. Tachycardia, shortness of breath, rales, coughing, weakness can lead to coma and death. Increase of fluid in the brain leading to increased intracranial pressure. So this is high altitude cerebral edema. Some lack of coordination, decreased level of responsiveness, seizure, headaches, vomiting, and coma. When we talk about lightning injuries, Voltage can be defined as a measurement of energy within the electric circuit at a given point. Current can be defined as a flow of electric charge through conductive material. Current referenced by unit of measure is called amps or amperes. The voltage and current of lightning is extraordinarily high, in excess of 1 million volts with 200,000 amps. Direct strike. Lightning hits a victim first before making contact with any other object. A contact strike can be defined as lightning hits objects with which patient is in contact. Side flash strike can be defined as lightning hits an object and then jumps to the victim who is located nearby. Ground current strike is lightning energizes the ground, affecting the people standing in the area of the strike. Be alert for associated traumatic injuries. General assessment and management ensure the scene is safe. Lightning strikes affect many body systems. Energy produced by lightning strike causes injuries along its path throughout the body. Management supportive. Treatment of burn injuries, musculoskeletal injuries, spine injuries, cardiac arrest. Here we have an image of a lightning strike injury. It looks like maybe the entrance is here in the arm. And that is it for our chapter. I will upload it now, and I will see you guys in class.